Dr. Robert Meyerberg Endowed Lecture in Cardiovascular Medicine was established in 2011 through a fundraising campaign to support an annual lecture in the Division of Cardiology and Department of Medicine at our medical school. Former fellows and several grateful patients donated to the endowed fund, which provides the means to bring in our lecture today. This is actually our 4th annual Meyerberg Lecture. And now Chad will introduce our special lecturer. Thank you.
Hi, thanks for joining us today, everyone. Dr. Gordon Tomaselli became Dean of the Albert Einstein College of Medicine and Executive Vice President and Chief Academic Officer at Montefiore Medicine in July 2018. He's an expert in the fields of sudden cardiac death and arrhythmias. His lab has been continuously funded by the NIH for over 25 years. He holds several patents on methods to improve heart function and prevent arrhythmias. Dr. Tomaselli came to Einstein from Johns Hopkins School of Medicine, whose faculty he joined in 1989. In 2009, he was named Chief of the Division of Cardiology. He was also a mentor to dozens of postdoctoral and clinical fellows, as well as graduate and undergraduate students. While at Hopkins, he was the Michael Murawski, MD Professor of Cardiology and Professor of Medicine and of Cellular and Molecular Medicine. He earned his undergraduate degree in biochemistry and chemistry from the State University of New York at Buffalo and his medical degree from Einstein. He completed his medical training, residency, and research fellowship at the University of California at San Francisco. He was then a clinical and research fellow in cardiovascular medicine at Johns Hopkins School of Medicine. He was elected to the American Society of Clinical Investigation in 1996 and has been a member of the Association of American Physicians since 2010. He has served on the editorial boards of a number of journals in cardiovascular science and medicine and has been a member of study sections for the NIH, AHA, California Tobacco Research Fund, and a member of review panels for grants from a number of organizations. He was the president of the American Heart Association from 2011 to 2012. He was the editor-in-chief of the Journal of Clinical Investigation from 2017 to 2018 and is now the journal's deputy editor. Please join me in welcoming Dr. Tomaselli as he talks about the cardiovascular complications of neuromuscular disease.
Thank you, Chad, for that kind introduction. In the spirit of imitation being the sincerest form of flattery, this morning I talked a lot about remodeling in the failing heart and its predisposition to development of arrhythmias. And a lot of that work was inspired by the work of Bob Meyerberg, who's been a leader in our field for decades. This is probably a little bit less directly in the spirit of imitation, but as Bob has progressed in his career, our interests have dovetailed in the sense that I've gotten more interested in heritable forms of heart disease and heritable forms of diseases that manifest themselves as cardiovascular disease. And what I'm going to talk about today is something that I've been doing for perhaps the last 15 or so years clinically at Johns Hopkins and hope to do a little bit at Einstein in my new position. And that is really see patients who have primarily neuromuscular disease, but neuromuscular disease that has a footprint in the heart. So the objectives of this study are to provide you with an overview and classification of various forms of neuromuscular disease, focusing on those that have cardiac manifestations, both arrhythmic manifestations as well as myopathic manifestations. The arrhythmic manifestations occurring in things like myotonic dystrophy and certain forms of limb-girdle muscular dystrophy. And the cardiomyopathic versions are in things we're very familiar with, Duchenne, Becker, and other forms of limb-girdle muscular dystrophy. So why is it that we as internists, and despite the fact that I've been a cardiologist for a long time, I still consider myself an internist, maybe not a good one anymore, but at least I still think I have the credentials to do some internal medicine. But why is it that internists need to know about these diseases and the protein manifestations of these diseases? Well, they do affect multiple organ systems. And the first line of defense is oftentimes the internist or the family practitioner when somebody presents with a manifestation of neuromuscular disease. Turns out that the reason that these diseases kill people has very little to do with the brain or the peripheral nerves, but a lot to do with the heart and the lungs. And early detection, I think, can improve both the quality of life and longevity in many patients who have neuromuscular disease. And kind of as a corollary to that, identification of mutation carriers may also allow for preemptive therapy that, again, further enhances life of patients with these diseases. So let me start with a case. This is a woman that I saw at the time. She was 40 years old, and the diagnosis wasn't a mystery at this point. She had a family history of myotonic dystrophy type 1, and I'll come back to this later. She was referred to me for evaluation of palpitations. She had significant myotonia, grip myotonia, tongue myotonia, so when she gripped something, it took her a long time to kind of release her grip. She didn't articulate well because she had tongue myotonia and couldn't really speak very well. She also had ptosis, and we'll come back to that as well, and a history of goiter with no history of hyper or hypothyroidism. She had no diabetes. She did have 3 children. One of them was affected with an infantile form of this disease, which is quite devastating. And when I first saw her, now 9 years ago, she had an electrocardiogram that, other than a mild interventricular conduction delay, didn't look too bad. We did a cardiac MR on her, and I'll explain why we did that at the time. She had normal left ventricular function and an ejection fraction of 57%. And with late gadolinium enhancement studies, she had no scar visible on the heart. So, with that as a background, let's talk a little bit about neuromuscular diseases. They are classified typically in a variety of different ways. They can be classified clinically based upon their presentation, genetically based on kind of the molecular or genetic basis of the defect in muscle function, and also pathophysiologically. These diseases occur with virtually every type of genetic transmission you can imagine. As you know, Duchenne and Becker muscular dystrophy, as well as Emery-Dreifuss muscular dystrophy, are X-linked. That doesn't mean they exclusively occur in boys. In fact, heterozygous carriers, women, oftentimes will have some manifestations of muscular dystrophy. They are transmitted as autosomal dominant traits. Myotonic dystrophy is one of those, and this is due to triplet nucleotide repeat. Myotonic dystrophy type 2 is a quadrinucleotide repeat disease. And then facioscapular humeral muscular dystrophy, as well as certain limb girdle muscular dystrophies, discal muscular dystrophies, and oculopharyngeal muscular dystrophies are also transmitted autosomal dominantly. And they are also recessive forms of this disease. The most common, numerically, forms of myopathies are those that are acquired. There's usually toxic or metabolic due to mitochondrial disorders or, in fact, treatment with various kinds of drugs. In our world, in cardiology, statins are a big component. So when there's a heritable form of neuromuscular disease, typically these occur in the dystrophin-associated membrane complex, which is a multi-protein complex that lives at the cell surface, but reaches down into the intracellular space and, in fact, to the contractile apparatus in both cardiac cells and in muscle cells, and also connects in a way to kind of stabilize and give a platform for contraction to the extracellular matrix. There are multiple components, as I mentioned, the dystrophin complex, but also the sarcoglycan complex, dystrophin itself, syntrophins, and some actin can all be abnormal in these forms of muscular dystrophy. Again, these are further subdivided into dystrophinopathies, sarcoglycanopathies, and laminopathies, which I'll talk about a little bit, are a particular form of these diseases that are due to defects in nuclear lamins, and these nuclear lamins do influence muscle function profoundly and also have a fairly onerous arrhythmic footprint. So these we actually look for pretty aggressively. As I mentioned, myotonic dystrophies are nucleotide repeat diseases, and there are a number of diseases that I won't talk about that are due to mitochondrial defects, mitochondrial DNA dropout, and other mitochondrial defects, including Friedreich's ataxia, Barth syndrome, and Kearns-Sayre syndrome. So, this is a table that describes what I, as a cardiologist, look for when somebody presents with one of these neuromuscular diseases. It turns out that the platforms and the manifestations are either arrhythmic, myopathic, or a combination of both. The myotonic dystrophies tend to present as conduction system disease, oftentimes bradycardias, more than tachycardias, although late tachycardias and atrial fibrillation are components of this disease. Becker and Duchenne muscular dystrophy tend to have arrhythmias late in the course, so well-established myopathic disease, then complicated by various forms of arrhythmias. Similarly, limb-girdle muscular dystrophy 2C through E and I, these are the sarcoglycanopathies. The laminopathies, as I mentioned, tend to have more in the way of conduction system abnormalities. There's a debate about Emery-Dreifuss. In fact, Emery-Dreifuss muscular dystrophy has been reported to be associated with sudden cardiac death in the context of relatively normal heart function. As mentioned, Kearns-Sayre syndrome, and perhaps the only muscular dystrophy that really doesn't manifest significantly in the heart is the autosomal dominant form of facioscapulohumeral muscular dystrophy. Okay, and again, you can think about these things as cardiomyopathy preceding tachyarrhythmias, driving the tachyarrhythmias, and again, dystrophinopathies and limb girdle. And in a very simplified fashion, the other component of those that are characterized by primordial conduction system disorders that may in and of themselves lead to cardiomyopathy, either by virtue of the development of tachycardia or by virtue of the development of conduction system disease that leads to dysynchronous contraction of the ventricle, the contraction of the ventricle itself, leading to left ventricular dysfunction. And I'll spend a lot of time talking about myotonic dystrophy types 1 and types 2, and a little bit of time talking about these other diseases. Like virtually any other disease that we think of, assessing for the cardiovascular risk in neuromuscular disease, the history and physical examination really are paramount. Not only the history, personal history, but family history is very informative in this and other genetic or heritable forms of disease. Physical examination is important because there are many extra muscular stigmata of these diseases, and I'll talk a little bit about those. The other things that we complement history and physical with in our neuromuscular diseases clinic are electrocardiography, both 12-lead basal electrocardiography and ambulatory electrocardiography, as well as stress testing, but for reasons that might be different from the reasons you do stress testing, more to look for chronotropic competence and what happens to the conduction system when stressed at higher rates. And we, again, maybe that's because where we came from, we had a very strong MR group, but we did a lot of imaging that was MR-based imaging, looking for structure, function, and the character of the myocardial wall, particularly to see if there's anything that suggests scarring in the myocardium. So type 1 myotonic dystrophy is the most common acquired muscular dystrophy in human beings. It's eponymously known as Steinert disease. And there are, again, as I mentioned, two genetic types. Type 1, or Steiner's disease, is due to a triplet nucleotide repeat, chromosome 19, in a protein kinase called DM protein kinase, dystrophic myotonica protein kinase. It's unlikely that this upsets function of this kinase, but I'll come back to that later. Type 2 myotonic dystrophy is due to an expansion, quadrinucleotide expansion repeat in a transcription factor called ZIMF9, also known as CNBP. There are pockets, demographic and epidemiologic pockets of these diseases, type 1 being very common in French Canadians. In fact, we had a fellow in the lab who was from Quebec, and she sees lots and lots of these patients in her practice now, less commonly in Asia and South Asia, and very rare in African blacks. So Europeans really are a reference population here. Again, the characteristics are weakness and myotonia, failure to release grip. But other manifestations include frontal balding, cataracts, and these are Christmas tree cataracts. They're iridescent seen in a slit lamp that are reminiscent because they sparkle of Christmas trees, and a number of endocrine abnormalities, hypothyroidism, hypogonadism, and overall, facial muscle weakness leads to this type of appearance, which is often referred to as hatchet faces. There's a drooping mouth, ptosis, and wasting of temporal muscles as well as other facial muscles. Type 2, again, is seen primarily in people of European extractions. Much milder muscle symptoms, tends to start proximally and work its way distally. Type 1 is more distal to proximal. And in fact, the symptoms here or oftentimes people just can't get up out of a chair or off the commode. Cardiac manifestations are later in onset. However, there is an accelerated form of atherosclerosis that can occur in some patients with type 2 myotonic dystrophy. Cataracts also occur later in age, and those with the most severe muscle disease tend to co-segregate with mutations or variants in a chloride channel, which is important for skeletal muscle function, and this gene called SCN5A, which is the sodium channel that governs excitability in skeletal muscle. So again, to just kind of highlight the difference between the two types of myotonic dystrophy, myotonia weakness distal more common here. Patients with type 2 myotonic dystrophy tend to present with more muscle pain even than weakness and myotonia. Same but different frequencies of these extra skeletal muscle manifestations. Diabetes, common in type 1, not so common in type 2. The inheritance in both cases is autosomal dominant, and both inhibit, although type 1 inhibits this phenomenon known as genetic anticipation, which means that subsequent generations of people that are affected with disease tend to have disease earlier and tend to have more severe disease. That's because over time and with DNA replication, these expansion repeats tend to get even larger. The larger repeats are generally associated with more severe symptoms. And there is a maternally transmitted congenital form of type 1 myotonic dystrophy, and we'll talk about that now. This congenital form is recognized at birth. These infants are very floppy, oftentimes have respiratory failure. If they survive, learning disabilities and intellectual disabilities are common, and cardiovascular complications are common. On chromosome 19, the normal length, there is a repeat in the normal circumstance, and it's up to about 35 CAG repeats. Once you start to get beyond that, then the consequences of those repeats for DNA replication and other things start to manifest themselves. In type 1 myotonic dystrophy, there's an enormous number of repeats, over 1,000 here, again, onset at birth. A bit more commonly, but less commonly than classic type 1 myotonic dystrophy is childhood onset myotonic dystrophy. This presents usually as facial weakness, difficulty talking, myotonia, and oftentimes learning deficits as well as conduction defects. The length of the nucleotide repeats really quite variable here. It can be anywhere from 50 to 1,000. And this heterogeneity is really pretty commonplace in even Mendelian transmitted heritable diseases. And it speaks to the complexity of gene regulation and, in fact, the interplay of other genes in the phenotypic manifestations of this disease. Classic myotonic dystrophy is diagnosed in adults, and adults that have had progressive muscle symptoms, usually myotonia, some weakness. Conduction defects are common. Insulin resistance is also seen fairly commonly, and you should think about this anytime somebody comes to you in your clinic and they've been seen and had a cataract done and they're below the age of 40. Oftentimes this is one of the reasons that this might happen. Typically, late onset is diagnosed in the parents of probands who've basically peacefully coexisted with their muscle weakness or myotonia and really don't have much in the way of manifestations, tend to have the lowest number of repeats. And the oldest person I identified as having myotonic dystrophy was in his early 90s. So he did well. All right, so what's the pathogenesis? There's been a number of debates about how this disease works and how you get a large overlap of the manifestations with nucleotide repeats in two separate genes with two separate functions. So one of the things that we disavowed ourselves early on is that haploinsufficiency of the two genes where the repeats occur is probably not the only or even the main mechanism by which this disease manifests itself. However, one of the things that does happen when you have nucleotide repeats is you get this higher order structure of RNA. And it's believed that most of the disease manifestations are the result of RNA toxicity. And this RNA toxicity can occur in several pathogenic mechanisms. So if you have nucleic acid that's folded like this and that lives in the nucleus, it can lead to chromatin disruption in and of itself. The other thing that these RNA molecules do is they sequester proteins that are involved in RNA processing. alternative splicing, and so on and so forth. Muscle blind is one of those that's particularly important in RNA processing that's involved in the development of skeletal muscle, and this occurs both in the cytoplasm and in the nucleus. There's also elaboration of binding proteins that are directed towards these nucleotide repeats, these CUG binding proteins. These binding proteins, again, are upregulated, and they in and of themselves can result in dysregulation and alternative splicing and translation of a number of genes that explain some of the diffuse manifestations in those genes include the insulin receptor, the chloride channel, which is important for skeletal muscle excitability, troponins, ryanodine receptors, SERCA, and calcium channels, which are important for calcium regulation both in the heart and in the skeletal muscle. So probably multifactorial changes that produce RNA-induced toxicity. These CUG encodes glutamine and polyglutamine. By RAN translation, peptides are made as well as antibodies, and these can be in and of themselves toxic if enough of this protein is made in a cell. And finally, there's altered expression of other molecules that might bind in these places, 3' untranslated region and other intronic regions of this gene, including microRNAs. And then in the setting of cardiac conduction abnormalities, we know that in fact in type 1 myotonic dystrophy there's dysregulation of MIR1, and MIR1 we know is involved in the production of the main intercellular ion channel called connexin 43, as well as the alpha-1c calcium channel in the heart. So multiple potential mechanisms of disease, probably each contributes differentially depending upon the specific manifestation. Okay, so let's get back to the clinical phenotype. We have recognized for a while that these diseases are disproportionately associated with an increased incidence of sudden cardiac death. And unlike classic cardiovascular disease, where sudden cardiac death may occur kind of in an older age group, maybe with established coronary disease, these occur in patients who tend to be pretty young. And these sudden cardiac deaths may equally be the result of too slow a heart rate as opposed to ventricular tachycardia, ventricular fibrillation. We also recognize that these are associated with early onset conduction system disease, and one of the problems here is that these diseases, conduction system diseases, are progressive and they're unpredictable in their course, so we tend to intervene early here, and by intervention I mean rate support, usually with pacemaking. Atrial fibrillation is common, and in some forms of neuromuscular disease are associated with an increased risk of thromboembolic complications. So even if somebody's got a Chad's VASC score that's relatively low, we generally tend to anticoagulate them. There will be a number of people over time who will develop left ventricular dysfunction. It is rare for folks to develop congestive heart failure, though, in these diseases, in myotonic dystrophy. So we've identified people at risk by serial resting and dynamic electrocardiography. We've imaged, as I mentioned, a lot of these people to look for regional fibrosis. And we've also done EP studies, selected EP studies, mostly program stimulation to look for inducibility, but we don't do that unless the patient has another reason to be in the EP lab, or we're anticipating putting a device in them anyway, like a pacemaker. We'll do program stimulation, see whether or not they have a tachyarrhythmia that's inducible, and that may change that implantation from a pacemaker to a pacing defibrillator. Again, keeping a close eye on risk factors for atherosclerotic cardiovascular disease, hypertension, hypercholesterolemia, diet, blood sugar is important, particularly in myotonic dystrophy type 2 and in those myotonics who develop glucose intolerance and diabetes. So these are relatively rare diseases, although as rare diseases go, relatively common for a rare disease. They're still pretty rare. And there's little data like we're used to in the cardiovascular world, where we study tens of thousands of people with coronary artery disease to try and figure out what the best therapy is. One of the largest early studies was by Bill Groh and Doug Zipes, and this was in a series of 23 muscular dystrophy clinics across the Midwest. They enrolled over 400 patients with type 1 myotonic dystrophy, and they defined this as anybody who had a repeat expansion greater than 38 CTG repeats or CUG repeats, or had a clinical diagnosis of myotonic dystrophy. And they asked the question, is there an electrocardiographic signature that helps us risk manage these folks? In fact, they defined a severe abnormality as the ECG of any one or more of these four components. So a rhythm other than sinus. Remember, these are young people, so somebody presented with atrial fibrillation, that was a severe abnormality. First degree AV block with a PR greater than 240 milliseconds, intraventricular conduction delays, QRS greater than 120, and more advanced AV block. And what did they find? So it turns out that in their cohort of 400 people, about a quarter had what would be defined as severe ECG abnormalities, and they were young, in their 40s. 75% a little bit younger, but had no severe ECG changes in this cohort. And interestingly, there was an equal distribution of men and women. And in about 6 years of follow-up, there were 20% of these people had died. So again, this is mean age of 40, 20% deaths, 5 years of follow-up with a mean age of death of 54 years. And about 7% of them were sudden cardiac deaths. The rest were, as you might imagine, a non-sudden respiratory failure, cardiac and other diseases. Everybody was imaged, usually with echocardiography, 7 patients without and 21 patients with severe ECG changes had left ventricular dysfunction. Heart failure, though, was exceedingly rare, both with and without ECG changes. And in fact, if you had a severe ECG abnormality that wasn't a tachyarrhythmia, you were more likely to develop a tachyarrhythmia like atrial fibrillation. So we had our own experience when I was at Hopkins, and again, I was seeing these patients for about 20 years, and we collected a proband group of 168 patients. These patients were actually even younger than Bill's group. They were mostly men, and they had mostly type 1, but a smattering of type 2, with a typical expansion repeat size, and were treated with kind of the usual medications, preventive medications, but a lot of them got mixilotine, and I'll come back to that in just a minute. Left ventricular function was borderline normal, and about 11% had frank left ventricular dysfunction. On the initial visit for these patients, most everything looked pretty reasonable. Conduction seemed to be pretty reasonable. Heart rate was reasonable. If these folks got, over the course of this observational study, 37 patients got implanted devices of some kind, either dual chamber or single chamber pacemakers or defibrillators or resynchronization or cardiac resynchronization defibrillators. Most of these were pacemakers, and a substantial portion, about 13%, had atrial fibrillation. After 5 years of follow-up, we noted in this group that 30% of patients developed QT interval prolongation. Maybe not enough to put a pacemaker in at that time, but 30% developed prolongation of the QT interval, a frank IVCDF that didn't start with one. And 11 developed left ventricular dysfunction, so going from a normal EF to a subnormal EF. Prevalent atrial fibrillation seemed to be something that correlated with the development of left ventricular dysfunction. So that complicates, I think, that assessment a little bit. We did modeling of parameters of these diseases to try and figure out who might be at risk for developing things that might prompt the implantation of a pacemaker or that might prompt us to do something else about left ventricular function. And it turned out that the features that were most important in picking out those people who were destined to have a prolongation of the QRS were their age at diagnosis and a family history of sudden cardiac death. Those people with type 2 myotonic dystrophy and those people that had a higher ejection fraction were far less likely to have QRS prolongation. And there were two features that predicted left ventricular dysfunction in this cohort, and that was the QRS, prolongation of the QRS interval, as well as type 2 myotonic dystrophy. So this is actually inverted. If you had type 2, you were less likely to develop left ventricular dysfunction, hence a negative coefficient. Similarly, if your QRS was shorter, less likely to develop left ventricular function, again, a negative coefficient for this model. So Saman Nazarian and I looked at a bunch of patients who had myotonic dystrophy, trying again to figure out who might be those most well suited to early intervention with pacemaking therapy by virtue, or treatment for left ventricular dysfunction based upon imaging parameters, and he developed a delayed enhancement intraventricular variability metric that seemed to correlate well with the total degree of fibrosis, but also the variability of fibrosis from segment to segment in the left ventricle. And he found that there's a pretty good correlation between the cure restoration in a pilot study here, between DEIV and total cure restoration, as well as a number of signal average ECG metrics that also were associated with conduction system delay. So we use MR imaging to inform therapy in these patients quite often. So let's come back to our patient. Again, reminder, 40-year-old with myotonic dystrophy, but no obvious cardiovascular manifestations other than an IVCD. Well, she was lost to follow-up for 3 years, and in the interim, she developed more myotonia, more weakness. She also was diagnosed with type 2 diabetes a year before I saw her again, and she had palpitations but no syncope. And again, this is a 40-year-old woman in the course of 3 years, went from an electrocardiogram that looks like this with a little bit of an IVCD to somebody who has a frank left bundle branch block. And we basically admitted her and repeated her MR and put in a pacemaker before she left the hospital. So again, cardiac abnormalities in these neuromuscular diseases parse themselves out into electrical and rhythm disorders and structural disorders. Again, myotonic dystrophy tends to be a situation where the conduction system problems predominate, and secondarily, things like left ventricular function may occur. Now, she had relatively preserved left ventricular function even with this left bundle branch block. So she did not get either a CRT device or a defibrillator because her left ventricular function was normal. So how do we manage patients with myotonic dystrophy? Much of what we do is supportive. It turns out that myotonia is very well treated. Skeletal muscle myotonia is very well treated by sodium channel blocking drugs, and in particular, mexilotine. However, we need to be careful about using this drug, because in patients who have pre-existing intraventricular conduction delays or AV block, this can be made worse by the presence of mexilotine. So either the patient has to be free of conduction system disease, or we admit them for starting the drug in hospital and monitor them. Pacemaking and ICD support, I think, is an important component of management here. These people can live relatively normal lives as long as we keep at bay the severe cardiovascular complications. I think that one of the reasons for us moving to imaging and to doing program stimulation is that despite the fact in Bill Grove's study that the patients who got pacemakers had a lower sudden death rate, the sudden death rate was not zero. And in fact, there was still a substantial proportion, about 7 or 8% of patients who had pacemakers who died suddenly. The thing to be aware of when you're being asked to weigh in on the management of these people is if they're going for any procedure, myotonia can be exaggerated by anesthesia, particularly depolarizing relaxants and anticholinesterases. Barbiturates, opiates, and benzodiazepines takes a long time for these folks to recover, and apnea is pretty common. There was, in addition to supportive therapy, a company called Ionis, which used an antisense oligonucleotide to target the triplet nucleotide repeat, particularly that was targeted for the insulin receptor. Unfortunately, this trial was stopped because of futility. There wasn't an adverse side effect, but there was no effect of the antisense oligo on the outcome of patients with myotonic dystrophy. There are a couple of other therapies in the works that may be starting soon. Coming back to mexilotine, again, we found this to be very useful, and patients have found this to be very useful. And there was a study now 9 years ago in about 40 patients looking at 2 doses, 150 and 200 milligrams 3 times a day. And these are grip, force profiles, grip and release. And what you can see at pre-treatment in patients with myotonic dystrophy is a delay, not so much a delay in development of force, but a delay in relaxation. And that delay in relaxation, despite the fact that the overall force generation is dramatically reduced compared to a normal control, the delay and myotonia is actually substantially improved. And this symptomatically is produces wonders for patients, not only in activities of daily living that they use their hands for, but also in speech. They also have esophageal problems, and in several of our patients, esophageal dysmotility and dysphagia have improved substantially. So this is our approach in the cardiac evaluation of patients with myotonic dystrophy, particularly asymptomatic. If somebody presents with symptoms, obviously they're going down a pathway where they're getting here relatively quickly. But we look for the presence of asymptomatic conduction system disease or cardiac arrhythmias. If we don't find those, we do periodic follow-up. And we're now in the process of writing a consensus document, and this consensus document is based on consensus of experts and not data, on how often to do this surveillance and what type of surveillance to do. However, if somebody's got conduction system disease and it's not new in onset, you don't know its duration, patient's truly asymptomatic, we will evaluate left ventricular dysfunction. We'll also do ambulatory ECG monitoring to see if there's any other signature of arrhythmia, atrial fibrillation, or high-density PVCs, and oftentimes in both cases get a cardiac MR to look for delayed enhancement. If in fact somebody's coming to the lab because they've got a low ejection fraction or have got some of these other risk factors, we'll do program stimulation to see whether or not pacemaker or defibrillator is the right way to go depending upon the particular clinical circumstances. So let me talk a little bit about some of the other less common neuromuscular diseases that have a footprint in the heart. And we have a relatively large clinic at something called the Kennedy Krieger Institute at Johns Hopkins, where we see many patients who have Duchenne and Becker muscular dystrophy. Remember, these are X-linked, and they're due to either the absence of dystrophin or an abnormal dystrophin. And the manifestations here are commonly cardiomyopathy and arrhythmias, but the arrhythmias usually tend to be secondary, not as presenting problems. So, Duchenne muscular dystrophy is the commonest of the inherited muscular dystrophies, about 1 in 5,000 live male births. It's X-linked. 30% or so are sporadic, mom's not a carrier. And like any eponymous disease, there's usually a backstory. And in fact, Duchenne had probably the better PR machine because about 20 years earlier, Edward Marin, an English neurologist or an English physician, described basically Duchenne muscular dystrophy, but it's not called Marin muscular dystrophy, it's called Duchenne muscular dystrophy. Again, dystrophinopathy, absence in Becker, absence in Duchenne, abnormal in Becker. And the process here is reasonably stereotypic. In childhood, weakness and wasting begins, usually starts centrally with pelvic girdle problems, and then distally and ultimately through respiratory muscles, a major cause of mortality in these kids. Moms that are carriers and those with Becker tend to have a more benign course. Again, oftentimes the delivery is normal, as is early childhood, and I'm talking about the first 2 to 3 years of life. Weakness really starts centrally along the pelvic girdle and the strap muscles, and wasting occurs late with contractures. There's an apparent loss of coordination. Fibrofatty replacement of the calves leads to kind of the pseudo-hypertrophy. Patients have a Gower sign where they're climbing up on themselves to actually stand up. They have a waddling Trendelenburg gait and lordosis to kind of compensate for the strap muscle weakness. And these children are often described even before they have these other symptoms of having a loose shoulder sign. Try and pick them up by the armpits and their arms just go above their head and they fall through your hands. These children develop an inability to walk in wheelchair bound by age 8 to 15, and death typically occurs in the 2nd to 3rd decade of life, although that's getting a little bit better with some more recent therapies. Myotonic dystrophy is associated with an elevation in muscle enzymes like CK, but it's very modest. In patients with Duchenne muscular dystrophy, CKs are through the roof, 50 to 100 times the upper limits of normal in early childhood, and in fact, they only get to be lower than that when it's end-stage disease and people have very little muscle bulk left. In fact, mild elevations early in the disease are really inconsistent with the diagnosis of Duchenne muscular dystrophy. Could be Becker, could be mom as a carrier. The electromyogram has a high-frequency component, myopathic pattern. These are low-amplitude, high-frequency components. It almost looks like myotonia, except muscle tone isn't increased, it's decreased. And when one does a muscle biopsy, as is the case for regenerating muscle, the fiber caliber is really quite variable. There's lots of cellular infiltrates, hypertrophied and regenerating fibers, and late fibrofatty replacement. If you stain for dystrophin in DMD, you will not see any dystrophin in skeletal muscle biopsies, and that's absolutely diagnostic. So dystrophin is, again, a supporting protein that links the extracellular matrix to the intracellular contractile and other apparatus, and it's expressed in skeletal, cardiac, as well as smooth muscles and to non-contractile organs like the brain. So in addition to skeletal muscle weakness, gastric distension, pseudoobstruction are common. Cognitive impairment is typically seen in many patients with DMD, although it's rarely severe. And in fact, many boys who have Duchenne muscular dystrophy are really highly functional. So when we're looking at electrocardiograms, are there stereotypic features in Duchenne muscular dystrophy? And this is one that probably highlights all the, it's not one that you see typically, but it highlights all the findings that one might expect to find in Duchenne muscular dystrophy. So it's a little bit of sinus tachycardia here. In addition, there's an increased amplitude of the R wave in the right precordial leads, so tall R waves, and lateral Q waves, which we probably wouldn't consider pathologic Q waves in many ways because they're not wide enough to be a pathologic Q wave. But that's the typical finding early in the disease. Later in the disease, it looks like a cardiomyopathic electrocardiogram, meaning, as in this case, the rhythm is not normal, it's atrial fibrillation. The QRS is of low amplitude, and that may be because of myopathy. There are nonspecific STT wave abnormalities, and there's conduction system disease, in this case, an incomplete right bundle branch block. So the ECG is not particularly helpful late in the disease, except to find other manifestations of cardiac manifestations of the disease. Doesn't really tell you much about DMD-induced cardiomyopathy compared to other things. So, as I mentioned, typically, cardiomyopathy occurs in these patients. It's really just a matter of when it's going to occur. Left ventricular dysfunction, most without symptoms, in a quarter of these patients, even when they're young, when you start to look at children under 6 years of age. And it can be present in older life in up to 50% of female carriers. And this is not typically the life-limiting problem in Duchenne muscular dystrophy. Often it's respiratory. It can be cardiac, but it's a combination of cardiac and respiratory. But it certainly can be life-limiting in Becker muscular dystrophy because the skeletal muscle disease is a lot less severe. Abnormal conduction and abnormal ECG we talked about. Atrial fibrillation, ventricular tachycardia, and prolonged repolarization are commonplace late in the disease. Again, we have looked at our experience, and again, this is my previous experience when I was at Hopkins, looking at the age dependence of left ventricular function in a large cohort of boys who had Duchenne muscular dystrophy. Not surprisingly, at a young age, they start off with normal ejection fractions, and there is a pretty tight correlation with age and reduction in left ventricular function. So this has been supplemented by a number of other studies that have MR-based and have noted that, in fact, when one looks at left ventricular function and looks at the cardiac MR, you see that there's a pretty good correlation between the amount of late gadolinium enhancement, i.e. scar, in these hearts, and diminution of left ventricular function. Again, you know, maybe it's in the spirit of if you go to a barber, you get a haircut. We have a great MR group at Hopkins, and in fact, we use MR extensively to help manage these patients. The other thing that we've used is ambulatory electrocardiographic monitoring, based upon a number of studies. But an example is that Holter monitors in a number of young myotonic dystrophy patients was used to determine whether or not there were abnormalities that were associated with left ventricular function. In fact, Holter abnormalities such as non-sustained atrial and ventricular tachyarrhythmias were seen, and these things tended to correlate with low ejection fraction as well as advanced stage. And advanced stage in the Duchenne muscular dystrophy world is somebody who's north of 15 years old. So we've used a strategy to try and diagnose early rhythm disturbances that might impact patients' quality of life as well as their longevity. And for those that have frequent symptoms, we've either used a life patch or a standard Holter or event monitor. But more recently, we've been using, with the reduction in size and ease of implantation of implantable loop recorders as well as their longevity, we can record for up to 3 years or longer. We've implanted ILRs in these folks and have managed rhythm disturbances and intervened early on the basis of these implanted devices. Our approach has been that if a patient with Duchenne muscular dystrophy presents with an ejection fraction less than 50% and any symptoms at all, we'll usually implant an ILR. And the criteria for an ICD implantation in these folks for us is a low EF plus symptoms or documented ventricular tachycardia. Now, this doesn't necessarily mean that this patient's going to get a defibrillator. It means that we initiate a discussion about this because there are other issues around quality of life that are going to impact the patient's decision about wanting to have a device implanted. And this really leads to the potential problem. The risks of ventricular arrhythmias in Duchenne muscular dystrophy, particularly primary prevention, really aren't very well defined in this disease. We use the guidelines for cardiomyopathy to make our decisions, but it's not clear whether or not these situations really apply to those guidelines apply to these folks because they're not represented in any guidelines document. Given the comorbidity of these patients, we have a very long discussion with patient and family about the benefits of ICD, potential benefits of ICD, and we tell them that really we don't know about whether or not there's a true mortality benefit here. We'll always talk to patients about anesthesia and peri-procedural complications of not only any interventions that we do, but interventions by others. And again, as I mentioned, the value of ICDs in non-ischemic cardiomyopathy is less clear than in patients who have coronary disease-related ischemic cardiomyopathy, where, in fact, primary prevention defibrillators do have a positive impact. So, again, the way we treat these folks is supportive mechanically, musculoskeletally, ventilatory support. There are some therapies that might slow progression of disease, steroids, ARBs, which attenuate TGF-beta signaling, although this hasn't been proven in a randomized fashion yet. Cardiovascular treatment, we tend to, even with left ventricular dysfunction, without symptoms, treat early with pharmacotherapy, including ACE inhibitors. Pacemakers and ICDs, we have a discussion with if there are indications in the second decade of life. And we're particularly cognizant of the use of all therapeutics, including heart transplant, in patients with Becker muscular dystrophy, particularly if they have relatively limited skeletal muscle involvement. There have been a number of experimental therapies that are ongoing, including gene replacement. Now, these dystrophins are huge, so you can't use a gene therapy with entire length dystrophin. So many dystrophins have been used in a gene therapy type of approach. There have been plasma membrane stabilizers, which actually plaster over rifts in skeletal muscle membranes, poloxamer 188, stem cells and antisense oligonucleotides. And I still think we're waiting to hear about what works best, if anything, in this circumstance. So I want to end with two diseases that have particular resonance with cardiac electrophysiologists, and that's limb-girdle muscular dystrophy type 1B, which is due to mutations in one of these nuclear envelope proteins, lamin AC, where in fact sudden cardiac death is a not uncommon presentation, and Emery-Dreifuss muscular dystrophy, where in fact sudden cardiac death is not an uncommon presentation. So what does that mean for us? We are particularly aggressive at looking for cardiac involvement in these cases. We are particularly aggressive at doing genetic testing in family members who present with limb-girdle or Emery-Dreifuss muscular dystrophy, because we believe the gene defect itself may put somebody at risk. We look carefully at ECG manifestations, and these two diseases, when atrial fibrillation occurs, is associated with an increased risk of stroke. So despite the fact that, as I mentioned, they may have a CHADS-VASc score that on its face doesn't justify anticoagulation, will typically anticoagulate these patients. And if somebody happens to present to us and presents to us in a way where a pacemaker would be indicated, typically that patient won't get a pacemaker, but instead they'll get a defibrillator because of the high risk of sudden death. So I think I'm just about time for a few questions. So let me summarize by saying, I hope I've convinced you that cardiac involvement in muscular dystrophies is common. There are distinct manifestations in these neuromuscular diseases. It's important for internist family practitioners to understand this because, again, they're the first line of defense. There's a gap in our understanding of the risk factors for both arrhythmia, sudden death, and also all cardiac manifestations here. And I think we need ongoing registries and observational trials from multiple sites to try and figure out what the best course of management and follow-up for these folks is. There are a number of folks who contributed to this. We have an incredibly supportive neurology group at Johns Hopkins that are interested in taking care of these patients, particularly Catherine Wagner, Dan Drockman I worked with for many years, as well as Andrea Korse and Charlotte Sumner. My colleagues in cardiology, Andreas Barth, is now really seeing all the patients pretty much with muscular dystrophy from the electrophysiologic point of view. Saman Nazarian's now at Penn. Joao Lima is our imager. Henry Halpern is another imager, and Dan Judge at the Medical University of South Carolina. He was seeing all these patients before Andreas and I, and a number of folks in radiology, as well as in the School of Public Health. So now you can clap if you want. I want to thank you. I want to thank you, and happy to take any questions that you might have.
Thank you so much.
Pleasure.
We have time for one or two questions. Yes, Efren.
Just a comment. So we have an internal medicine pediatrics training program here. It's a great bridge between our pediatric genetics and our adult cardiology. So thank you for your work.
Pleasure. Thank you.
As a member of the MedPeds group, for pediatric, like anyone who's doing screening, what strategies do you recommend for someone who's diagnosed, and do you start getting ECGs at a certain age, or what?
The first thing I start with history and family history to see if I can come up with a diagnosis before I even to approach the child. Particularly, as a pediatrician, a budding pediatrician, it's one of these things where you don't want to be too aggressive with children too early, but you also want to make sure that if they have risk, you manage that risk. Duchenne muscular dystrophy should be apparent in early kids if they have it. Some of these other things not so apparent. If there's a risk of conduction system disease, yes, I would get an electrocardiogram. I would also get an ambulatory electrocardiogram that's targeted to these children in a way that we can manage to get some useful information. I also would consider, in certain forms of these diseases, an assessment of left ventricular function.
Thank you very much. Any more questions, please come on down.
Okay.